last decade, couple of decades, we can tell. And then, for this, at the beginning, I like to tell you one story. The poor knowledge of, inadequate handing over, poor communication between sending and receiver. In the recent past, about few days ago, one transfer from one private hospital to another private hospital. So that private hospital, the transfer private hospital doesn't have a proper intensivists or anesthetic cover for their ICUs. So obstetric patient admitted PIH, eclamptic fits, and then the fallen and probably head injury. And then only this obstetrician has assessed the patient and transported to the another private hospital where the whole facilities are available. So this, unfortunately, no proper airway trained doctor is available for transfer, no communication. So that VOG has communicated the the receiving and VOG. So actually, the original VOG is also not in the country. The another one has come for this receiving this patient, and then that he hasn't communicate with the intensivist or anesthetists at the receiving end. So this, so what has happened was receiving end, when patient reached the receiving end, patient's pupils fixed dilated because this patient was arrested during the transfer. The transfer team cannot do anything because the unintubated patient, so you can't intubate and ventilate during the transfer. So ultimately, both baby and the mother died. So this very young child, very young mother. So this is very unfortunate. So these are the failures of our system. If that, if actually I was in the receiving end, that's why I'm telling this thing, because if they communicated me properly on time, so I will not allow them to transfer this patient without intubating. So if they intubated and transferred properly and stabilized there and transferred, so actually we would have saved both mother and the baby. So this is so these things should not be happen in our country in the future. So we are anyway, ministry also has recognized these requirements, and then they are doing a lot of things. So I'm involved for the lot of things here. So we'll see how to improve these things. So this educating healthcare workers, that's what I'm doing at the moment, because it's actually I have started these activities since October, but I kept all the records over years and years. But this, so this, then we have started CPR programs at National Hospital from January onwards. We are starting outreach, CPR and transport programs in National Hospital. At the moment, it is limited to National Hospital, but in the future, we are going to expand to the other hospitals and island-wide distribution, and educating general public. This is also very important. So this patient transport, you know, this we have seen when there is a road traffic accident, these main transporters are trishaw drivers. So one is holding the head, other one is holding the legs, and then load to the three-wheeler. So the ultimately what has happened when patient become conscious, all four limbs are not working. So this quadriplegic and cervical spine injury. So therefore, this is so how to handle these transport, especially when there is a trauma, road traffic accident. So we should educate the general public. So in the trauma secretariat, we discuss about this thing, and then they give some educating the general public in the future. And then transport teams. This is very important. So we are preparing transport teams at National Hospital, and then I discussed with few hospitals to start transport teams, and we are giving training for them, how to assess patients, and then outreach and the CPR and airway management, and how to transport patient. What are the things we should consider? And auditing the patient transport. This is also important, because we have only UK statistics at the moment, because we think, because I have only working experience in UK when I was getting my postgraduate training. So this anyway, so when compared to the UK transport system, here we considered as only 1 or 0 to 1 level %. So this is so we have a at the moment we are considering the UK system as the best system. So we will try to improve the critical ill transfer system up to this UK level, but at least 50% if we can implement within a couple of years, it's better. And then this auditing is also very important to get our statistics, and to improve the we thought of every 3 months review all the transport audit, and then they improve our system. And then the certificate courses, that is also very very important. I have seen this anesthesia colleges doing lot of things on improving the transport of critically ill, and mainly for their sessions and separate courses also. And I invite you all to join them and learn how to transport of critical ill. And then we are going to start the certificate courses from the Ministry of Health as well. And then extension of outreach and transport. So we discussed with the Air Force to train our people for airlifting. And then so you see why I put sea trans, because in the COVID era, we had a lot of requests to see patients in the in ships, quarantine, and then they need to bring those patients to proper hospital when there is critical ill. So this it's not a easy thing. Sometimes you have to climb through specialized places to enter into the dock, that type of problem. So we can discuss in the future those things also. And the specialized transport, how to transport trauma, A, B, C, D, E. So then, and the head injury patients within golden hour, if we can transfer this head injury patient, most of the patients we can save. And then the other thing is the airlifting system is, if we can improve the airlifting system, National Hospital Trauma Center has a helipad. You can bring the patients within an hour in Sri Lanka. So we can increase the survival rate. And then the obstetric. What are the concerns when transferring obstetric patients and pediatric patients? We'll see in the future. And the recognizing healthcare workers, doing transport as a highly skilled people, because this we don't condemn this, or the not condemning, but this we consider those who are doing this transport are highly skilled, and then we keep them in the little high level in our setup, and that well transfer. For that thing, we are going to we can improve the transport system, the diplomas, even in the medicine, transfer medicine, because this one I can tell you, when I was getting my post MD training in UK, so I was not allowed to touch the patient for transfer until I finish my transfer assessments, DOPS and CBDs. So this is that's how they consider this transport of critically ill in very high status. So then those who are recognized as eligible for transfer patients, so this is a level, this is a high level. So this we should bring the this system to that level, right? Right. So this ultimately, I think for improving these things, today my main objective is to educate you all in Sri Lanka. So for this thing, we need to so we consider the UK system is the gold standard. So we'll see how they do all these things, how we can change our setup into that. So that thing we need to know some the technical terms and these things. That's why this the classification of the patient transfer, the position on the care path may be primary, secondary, tertiary transfer platform, road door air, urgency of the care, emergency, urgent, routine transfer, level of care, 1, 2, 3, level 1 care, 2, level 3 care, and then the intra-hospital, inter-hospital and international transfers. And then the primary transfers are so this transferring patient from the site of injury or the in the problem to the nearest hospital. But extended transfer is so this when you are transferring patient from the site of injury or scene of injury to the best care hospital. So this some maybe bypassing the nearest district hospital and bring the patient to national hospital. So this for head injury patient, because the neurotrauma center is in the national hospital. So that type of transfers are extended primary transfers, and then secondary transfers are from care hospital to another care hospital. So there may be emergency ward, critical care facility for operating the various options, right? And then the clinical transfers, clinical transfer patients, clinical transfers are the specialty treatment or investigation not provided at the referring hospital. So no investigation, no facilities. But the capacity transfer is there are facilities, but at that time no facilities. Therefore, transferring, right? And then the repatriation is the patient transferred back to referring hospital or the hospital near the hospital home address. So bring him back to home near the home. And then the inter-hospital transfer, we know this hospital to hospital, inter-hospital, within the hospital for CT, MRI, this type of thing, right? And then the theater, right? And then who involved? Usually the primary transfers are conducted by ambulance, right? We know this. We have a nice ambulance transfer system in Sri Lanka. I can remember this. We can go back to about 20 years, but about 18 years. this ambulance service also started at the National Hospital, and then it was limited to Colombo Municipal Council. So this luckily this in 2015-16 time, this government recognizes this ambulance service and took over all the things and improved to the extend to the whole country. So this is very good thing. Actually, you know this, the trauma secretariat has started this ambulance service in 2000. I can remember 2003 or 2004. I was a anesthetic MO medical officer those days. We used to train those ambulance drivers those days, right? How is Sri Lanka ambulance, and then so I can't remember exactly. I don't know whether this is 1990. I can remember. So there is a number for ambulance transfer. The people knows, and then they will call and bring the ambulance. Not try shows. So this is very rarely we see try shows are transferring patients, critically ill patients. So this usual other transfers are they are doing, and the secondary transfers are usually from hospital to hospital, like the well-established place to another established place. Most of the time, anesthetic team, critical care doctors, well airway trained doctors are taking patients. In some places, we have seen transfer teams, they made for the transfer only. So bringing team or this airway trained doctor from the anesthetic, call anesthetic consultant, and getting another MO anesthetist, and then the nurse from somewhere, and then we make transfer teams most of the time. The transfer process, before transferring the patient, we must identify patients that we can transfer. So this patient stability is very important. So better not to transfer unstable patient. If you are if patient need, sometimes there are instances we have to take the unstable patient as well, but usually not. An agreement between referring and check whether the referring center and accepting center, both clinicians knows about this thing. This is the biggest problem in our setup I have seen, because there is no agreement between referring and accepting center. I have seen some patients when they receive when they found an ambulance from peripheral hospital, this the major hospital people used to send a patient through with that ambulance. So so this no communication between two places. Sometimes these ICU patients are going to peripheral ICU, but we don't know whether they have ICU patient ICU bed or not. So how do they keep the patient? So this is very unfortunate. It's happening in Sri Lanka. So we should stop all these things. For that thing, you must know the how to send in patients. So a referring consultant should contact the receiving and consultant, and there is a consultant to consultant communication, MO to MO communication, and nurse to nurse communication. So this ICU team should know the referring ICU team and then the receiving ICU team. Both should have very good communication, right? Handover from critical care staff to transfer team. So that is also very important. Handing over. For that thing, you must, if you are not the transferring team member, so so you don't know. I have seen one case. So it has gone up to the inquiry level. So this one patient transferred, and then the no one to transfer that. Then I asked to transfer that patient with a MO. So this is ultimately, MO brought the patient to our ICU, but she doesn't know anything about the patient. So what her argument is, I was asked to take the patient, and then I don't know anything about. You can ask from the ward. So this should not be happen in the future, right? So this for this thing, you must be, if you are taking the patient, you must know about the patient well, and you get the nice handing over from the receiving end. If you are not from the receiving team, most of the time the transferring doctor is from the receiving unit in our setup. But on and off, we get this type of problems also. And then transfer between care facilities. So this one hospital to another hospital care facility, we have to check. And then the handover from transfer team to the accepting team, it should be in the proper way, and return transfer team and equipment base. This so why this this return transfer team and equipment to base? So you can't forget the equipment you take the patient with the patient. So the receiving end, ultimately, most of the time this is not happen, because this, this so nurses looking after those things, because otherwise the sister will, because sister has the inventory, and so this, she is finished, or she or he, without bringing all the equipment. So this is good administration, but there are instances, so we forget some equipments there, right? So the risk of critical care transfer. So these are highly theoretical, but see how many things we can learn to improve our critical care transfers from this thing, right? The technical things, and non-technical and organization. So this when you consider all this incident reporting, so these things are from UK statistics. Major physiological derangement 15%. So these when you are transferring unstable patients, so these things can happen, and the patient or relative dissatisfaction. So this is 7%. So you have to satisfy mainly everybody, right? Their prolonged hospital stay, 4%. Because of this transport of critically ill, the wrong way of transport of critically ill, and then the physical or psychological injury to patients, and death. So this how do you improve the outcome? So reduce the adverse incidents, right? So the careful selection the patient, planning the transfer, and preparation of the equipment. So they say this 50 to 91% of these incidences can be prevented, right? So you can use some checklist for these things. Most transfer incidents can be limited. So simple rechecking of equipments, patients before transfer, and appropriate use of protocols. So you need to build up your protocols in your setups, and then we will try to make them and distribute to the country in the next year, in the first half of the next year. And pre-departure checklist, you must have checklist in our audit. So we can prepare this checklist also. So you can easily download and keep for in the future your wards, your ICUs, and if recording patient information, the normal cardiac and confidential rules should apply. Therefore, you can't divulge this information to everybody. So we have to keep it only for our transfer purposes, and then only from referring end to the receiving end. And right. So as we discussed with the risk, this technical risk, unstable patients. If you are transferring unstable patients, so high risk. Therefore, please stabilize patient before transfer. And then there are instances where we have to transfer even though unstable. So for example, PE patients for PTPA. So anyway, pulmonary embolism patients are, most of the patients are unstable. So you can't help. At least if you diagnose this thing early, we can transport and get the CTPA. But it's if there is a saddle thrombus, this type of thing, patient can get destabilized at any time. So this we have to get the CTP as early as possible. So that therefore, if you are transferring unintubated patients, so you are especially airway trained doctor should be accompanied for this type of thing. But this most of the CTPAs are done by house officers in our setup. That is very wrong. So this at least senior MO should accompany for CTPA. Or this you should ask for airway trained doctors. This we think this anesthetists are the optimum people for this purpose. But this unfortunately we don't have that much of team because they are involved for a lot of activities, right? And then the technical further technical problems, equipments, the power failures, oxygen supply failures. These things can happen, so we have to be careful. Then we must know how to calculate how much of oxygen required for transfer. We discuss in my lecture oxygen therapy. I don't know, I have done it through this same stream. Unfamiliar, because the transfer equipments sometimes differ from, because those who are transferring patients or the transfer MO nurses may not be familiar with the transfer equipment they are using. So this and then the transfer team each other may not be communicating well, because they are very new to each other, because that's why we need to have good transport team. And then so they know each other, they know what they are using, right? Missing, damage, compatible, or outdated. So this is also a problem. If we know the missing particles, damaged particles in the team, but this if you are very new to these transport teams, and then you must know these problems, our limitations of transfer patients and the dedicated equipment. Therefore, so we recommend dedicated equipments for patient transfer, and then well maintained. And the non-technical teams are technical things are team briefing. We know this. Most of the ICUs in Sri Lanka, they do the team briefing in the morning. And then why this is also another thing. And then before starting the surgery also, there is a small discussion between the anesthetist, surgeon, and then the nursing team in the theater. So this is why can't you do this for the patient transfer? So once you actually initially you should elect a team leader. So he should give all the commands, and then usually the airway trained doctor must be the team leader, right? And then give a team brief, and then you know what are the things you have checked your checklist, and we can check all these. In transfer involved them. Then when there is a small team working in isolation, these teams are often unfamiliar to each other. But this is in UK setup, but it when opportunistic opportunistically collected people and making teams. But there are transfer teams in the UK, most of the hospitals, and they they call them when there is a transfer or the qualified transfer doctors, nurses, and supporters coming for these transfers. So we have to build up this setup in Sri Lanka, right? This the organizational risk. So this in UK they have AAGPI for support for transfer, and then the Royal College of Anesthesia and Intensive Care Society. So they have their own insurance system. So if something happened during the transfer, so this sometimes you may not be covered because this transfer referring in hospital will tell that we are not responsible. We are sending this patient, and then the receiving end may tell that we have not yet received. How do we take the responsibility? So the ultimately your responsibility if something happened during the transfer. So this therefore you need to have a separate insurance scheme. But when you join to AGBI, they are giving a free insurance scheme for their members. So this other thing is transfer guidelines. So whether we have proper transfer guidelines, have we followed? So this I'm very happy. Sri Lanka, the College of Anesthetists and Intensivists of Sri Lanka has started transfer guidelines since 2013. I think I don't know whether it has updated thereafter. So so we should take these the anesthesia college guidelines further. So I'm happy at least we have that that guidelines and designated. So this when you are transferring patient, designated consultant who is responsible for transfer is the referring in transfer consultant. So he or she is responsible for guideline production and training, documentation, data capture, audits, and encouraging best practice for the sending team. So I'm happy. I have seen only one hospital, one private hospital is always calling the consultant on call before they are going for any transfer. So the ETU is always calling consultant. Earlier, so when I was doing on call for that hospital, it was little troublesome, but this ultimately so I thought that is a very good practice there, because this somebody should be responsible when they are transferring patient. Even when they are taking the patient from home or from trauma side, they inform that consultant, on-call consultant, and go. So somebody should be responsible. And then we need to know the late finishes need to be acknowledged for the rest time. You know, this Sri Lankan bus drivers driving sometimes continuously 24 hours. So without any rest. So that's why most of the accidents are especially in the highways and in long distance travels. So this so the same way in our setup also, sometimes if you transfer a patient from Colombo to Batticaloa, so this up and down, how many hours? So this they need help. This but it's in our setup we have only 4 hours of extra duty, and then so in other setups, so you know, when you go to railway or somewhere, so if they are they can claim bata extra duty, all these things when they are going long journeys. So this, but here our setup is not that very good. For that, at least we must give at least rest period before going for another transfer. So these things should be revised in our setup. And dedicated transfer service has many advantages. So this especially prolonged transfers, prolonged transports, right? And then the training and competency. So this AGBI stated that education and preparation are central to safe transfer. So this I'm doing this educating part even, and then we have already started preparing skills for all this. I have started CPR courses, course at National Hospital. All can join. And in the retrieval CPR and transport training from 2023 January. So National Hospital education doctor, you can contact her and join for them, and ultimately recommend personal undertaking transfer should have appropriate competencies, qualifications, experience. So this that's why we have started already started CPR programs, and we are qualifications. At the moment, we are giving certificates. Those who are getting the training, CPR hands-on training, and we so from January onwards, we increase the we include that transport of critically ill hands-on training also into this, and then the experience. And once you get the training, you need to join for transfers and get experience. And in big hospitals, you can see this. Transferring patient for MRI, there are a lot of things to be done. A lot of checklist, and then you need experienced staff for this thing, and then attendance at suitable transfer courses. So these transfer courses we have not yet started. Probably in the 2023 will be another year for patient transfer improvement. Transfer courses can be started. So we need resource persons. Those who like to join us, you can contact me at any time. And the regular training, including instructions and reflection of their technical and non-technical skills. And then checklist and so when you transfer patients, who are the patients we are going to take? So ideally, so stable patients with whom you are going. So this that is also important. You are taking airway trained doctors from the anesthetic team, or then the nurses from the ward, and the minor staff from the you call oversee and bring minor staff. So they don't know each other. So then what are the things we can do? And then when are we taking this patient daytime or nighttime? So what are the problems if you are going in nighttime? I can remember about a couple of years ago, I had to transport VIP patient from the Batticlaw to National Hospital. So this initially plan was to transfer on air. So this so ultimately, so it was the transfer was dragged and about 4 o'clock. Air Force team, Air Force refused to give their choppers to transfer this patient. Ultimately, we had to go by ambulance and bring the patient. So so because this nighttime is not good, because all the crashes happen during nighttime, so they don't usually entertain night transfers on air. And then right, how we transfer this? So on or road door, and then with what? So your equipments, right? What are the equipment we are taking? How many oxygen cylinders we are taking? Right. Whom? So appropriate technical reasons for escalation. So if there is, so when you are considering transfer, check why, if receiving and ask why you transfer this patient here. So you should have a proper answer for this question and enable more appropriate admissions, clearing beds, prioritizing. These may be the reason for taking this patient for transfer, and the most stable patient should be usually transferred, moved first, because unstable patient you have to stabilize and send, and then check whether the agreed by the responsible consultant in both referring and receiving hospitals. You may be the nurse or doctor or the team member, right? Check both in consultants are agreed, otherwise they will refuse, right? Supervision to transfer team is provided by the referring senior clinician. So this all the responsibilities with the referring consultant. So he has to take the responsibility. So with whom? And intra-hospital transfer, trainees work under distance supervision. When most of the time these patients are this intra-hospital transfer to MRI, CT. These the ICU consultant or this the referring consultant is responsible, and then you can monitor the patient in distance way, and then the transfer teams or individuals. So then usually the again referring team consultant is responsible. So where we stand. So check how we manage this type of transfer, and then the timing take longer. Sometimes take longer than anticipated. So we need speed and safety. So head injury patient need to be transferred ideally within 1 hour. So we need to check all these things. And in the non-urgent ambulance, depending on the task of care, can several hours to arrive. So this disrupting both referring and receiving hospital. So these things, the non-urgent ambulances, right? And then whether so we can take non-urgent things at any time. So provided referring and receiving ends are all right, and the daytime work hours is safer. I discussed this thing, and the night in bad weather carries additional risk. So I discussed that right. The fatigue and dangerous driving also important. So because this ambulance actually this I can tell you, I brought that patient couple of years ago from Batticlo to National Hospital. That patient, that driver was not slept for more than 18 hours. So if something happened, at least when we were coming back, so he was very tired. So I asked him to get a rest, and we all right. We will have a 2 hours rest and come. But this he refused. So this is the system in our setup. So we have to change this thing, because we don't have other ambulance drivers. At least if we have 2 drivers together, so one can sleep during the transfer until so he can get a rest and then change the driving. So these things not happen in our setup. And then how the careful preparation, airway breathing circulation, local guidance, specific targets for certain patients. So head injury patient within 1 hour. So we'll try. So airway things. So here the intubation and transfer. These things are very important, especially head injury patients. So if patient hypoventilated during the transfer, carbon dioxide is accumulated, and then the carbon dioxide can cause cerebral edema, and so these chances of survival is very minimal when they reach to the neuro center. So this that is usually it says about GCS, if it is GCS less than 12, should be intubated and transferred. But I say if it is less than 15 or this confused or something, some GCS little duration, we should intubate and send him for, because I have seen this the receipt transferring and says GCS 14 at the time of patient come to the National Hospital, GCS 3, and then when we do the CT, huge cerebral edema, sometimes cone. So this should not be happen. And then before transfer, tracheal tube placement should be checked. So why I ask this thing? Because ultimately the receiving end people may tell that is so during this has happened, the tube displays. See, this is your problem. So during the transfer, you have not take the patient properly. So therefore, this at least check the tube placement, lip level, and then the check with the X-rays whether if available. So these things tube secure, whether this tube is secure. So this is very important. And then the breathing, ventilation adequacy. So I told that if hypoventilated during the transfer, patient can end up with coning. So this also saturation probes, and when you are taking the patients, and so it should be nicely adhered, and then better if you can use this when the transfers. So pediatric lobes you can apply to your ear, and then sometimes in UK setup they have single-use adhesive probes also. And end-tidal carbon dioxide monitoring is also mandatory in UK setup, but here we can't find ETCO2 monitor even for ICU patients. So these are the problem in our setup. So we'll improve in the future. The government has recognized this transfer of critical is as a priority now. And then the pneumothorax should be identified, decompressed, and drained before transfer. At least we must send we must put a IC tube and send, and oxygen requirement should be calculated before transfer. I discussed this thing earlier. So this is Boyle's law. We know this 135 bar in oxygen cylinder. So so this at 135 atmospheric pressures. So this 1 atmospheric pressure, how much of volume of oxygen in the gas cylinder. So we can calculate if we are using if you are giving 6 liters per minute, we should be able to calculate this thing, right? This is simple. Boyle's law, P1 equals P1 V1 equals P2 V2. So I think most of your healthcare workers have done biology in the system advanced level, right? As with normal anesthetic practice, bag valve masks are essential. AMBU, you should not forget AMBU when you are transferring. So this water circuit should be available when you are transferring the patient. Circulation. Fluid resuscitation should take place during the transfer, because when there is a long way transfer, so patient may be fully dehydrated at the receiving end. So it should not be happen. And the thing is, IV cannula and should be nicely secured, especially central lines, art lines, because of this vibration going through when you are going in the ambulance. So these things can dislodge. So it should be nicely secured. And then and the disability sedation and adequate analgesia is very important during the transfer, because this is during the transfer a lot of stimulation, because this vibration can cause pain. And then the because you can't allow patient to struggle during the transfer, so patient should be nicely sedated and given analgesia appropriately during the transfer. So that thing you can use propofol, opioids, these things, and we consider the increased stimulation during transfer. Therefore, this sometimes you need more sedation than ICU patient during the transfer. So and then if required, need paralyzed and ventilated. And then the blood glucose should be checked before the departure and during the transfer, because if you are taking the insulin infusion, so patient can go into hypoglycemia. Patient might not wake up in the receiving end, and then when they are checking the CPS in the receiving end, if it is hypoglycemia, all the blood will come to you. So you must know how to check the keep the blood sugar level normal, right? And the seizure should be controlled. Actually the seizures during transfer is not acceptable. So you stabilize seizures, or at least you must discuss with the neurologists or neurosurgeons before sending the patient. For need at least seizure prophylaxis for head injury patient, trauma patient, like that. And then the intracranial pressure treatments we have to continue. And then the exposure. Trauma patient should have their cervical spine, pelvis, and long bone fractures immobilized as appropriate, because it's this transfer can dislodge these things. Therefore, it should be nicely packed, and all drains and lines should be securely fixed, and risk of hypothermia. So you might not think that is very important for in Sri Lanka, but these our new ambulances are AC, so this hypothermia can occur, and then therefore nicely covered. All patients should be nicely covered before sending for transfer. And then the temperature monitoring is recommended, but I have seen temperature monitoring mainly in our theaters. In ICUs also very difficult to find temperature probes, right? So this packaging is important. So we have to pack the patient nicely. That will reduce the movements, heat loss, snagging, and then injury during the transfer. In UK setup, see this crease and their clinical debris in sheet should be avoided to reduce the pressure area. So this, we have seen so many patients when you keep in the seated up position, there are a lot of creases can see in the backside, because this bed sheet is not properly stretched. So these things also important, because so I don't think we can go to up to that level, but it's very easy and simple things we can do. Trauma patient may require vacuum mattresses or splint that may be difficult to remove while maintaining full spinal precautions. And the patient need to be secured to transfer trolley. So next thing is you pack the patient nicely, and then securely secured to the patient in the trolley. Patient to the trolley. So patient initially you pack the patient, and then pack the patient to the trolley and nicely adhered, and then then trolley should be nicely secured to the vehicle. Then all the movements are the patient with the vehicle. So this we can minimize a lot of movements in that way. And so I why I put this picture here. So can you see this red bag with this lady? So this is the transfer bag. This is also very important. You have to keep everything in this for resuscitation. All the vital medication, resuscitation equipment should be in this bag. So everybody, every ward, every ICU, HDU has this type of transfer bag. So when you are transferring patient to even for CT, MRI, we must somebody should keep this, because the patient can get arrested in the on the way, right? So documentation is also another thing very much lacking in Sri Lanka. So recording vital signs can be challenging, but should be done every 5 minutes as per AGBI guidelines. But we don't have that proper things here. But we must start, especially. I haven't seen anything when patient is taking for CT or MRI. Recording the basal values or the present values before transfer. So I have seen in but that is the that's why I'm comparing with the UK system. They are when they are transferring patient even for MRI or CT, they write in the BHT, and these are the parameters: saturation this much, BP, heart rate. All the vital parameters are recorded before taking the patient to even for inter hospital, and then after coming back or the handing over the patient again, they record. These are the things, because otherwise when you take the patient, that is your responsibility. Therefore, so if we are taking unstable patient, then we know this we are taking unstable patient, and these are the blood pressure values. So you can't expect better than what you receive from the referring end, right? Therefore, very important to document everywhere. And the significant events, interventions, drug administration should be recorded. And then the additional details like the referring consultant name, transfer team details, timings, all these things should be recorded. And then the better to keep duplicates for audit and incident reporting. And if there is a case, so you can produce. These are the things we have done. So this you can take a photograph and keep in your phone. And a standardized documentation should be developed in our setup. There are standardized documents in other countries, but it's here, so we will develop in the future. And the communication and handing over. So this is communication. There is a huge gap in our communication and handing over in Sri Lanka. Ideally, this communication should be, I told, this consultant to consultant communication, MO to MO communication, nurse to nurse communication. So at least these three levels should be there. The good communication, smooth the transfer process and handing over process. And then the handing over of care is usually a 3 or 4 stages process. Firstly, the referring and receiving senior clinician should discuss transfer of care. And secondly, the referring unit should document a care summary and handing over letter. And then thirdly, the transfer team is not familiar with the patient. They should receive handover from the base referring. So they should hand over nicely to the transfer team. Most of the time in our setup, this the doctor or nurse is usually from the transfer the referring team. Therefore, no problem at this stage, but it's on and off we get problems. Finally, the transfer team should conduct structured verbal handover to both medical and nursing personnel. simultaneously, concentrating on any changes during transit. And mobile phone is essential for communicate during transfer from the receiving and sending in. And then, so these are the drugs we can take, the vasopressors, sedatives, neuromuscular blockers, fluids. So labels, lines, pumps, these things are the drugs. And then so these equipment should be durable, compact, and well maintained. Otherwise, we get unnecessary problems. Right, this equipments, these are the basic equipment we are taking when we are transferring ventilated patient, ventilator, infusion pump, monitoring, suction defibrillators, transfer bags, trolley. So these things should be nicely docked for monitoring infusions. Otherwise, if the vibration when ambulance taking when it should not move here and there, should be nicely adhere to the appropriate places. And then the by road or by air. So this Sri Lanka inter-hospital transfers are typically via ambulance. But very rarely we get air lifting also. So these things are depends on the urgency of care, geography, platform availability, weather, access to airports or helipads. So, by only clinician confident and competent in aeromedical transfer should undertake such missions. So this because if you are taking patients in helicopters, so you should have at least so knowledge of physiology of acclimatization. So because we must know the when you go up, the oxygen partial pressure is coming down, then the patient can get hypoxic if we are not taking adequate actions, right? And the care of the transfer team, this is also important. So this in COVID time, we had a lot of problems. We need sometimes we were lacking of personal protective equipments, PPEs for COVID-19. So you need to have adequate equipment for transfer, and then warm clothing. So you are going in the AC ambulances. Now earlier we didn't have these things because most of the ambulances are the normal vans converted into ambulance. But here now we have well-designed ambulance in our setups. Ideally, high visibility jackets. So you are going night time. That is what very important. Now the people recognize this this thing, because I have seen this even foot bicyclists also using these high visibility jackets, and then the mobile phones, food and drink. So this, you should have adequate money when you are going for long distance transfers. I can remember when I take that patient from particular, so that and I luckily I had enough money to spend for the whole team, because on the way we had two breaks. So that is also important, right? Insurance, you know this in UK AG, when you are a member of AGPI, you get automatically get a free insurance cover. But here also we need to build up those things for those who are, because this, you know, this sometimes the preferring hospital and then the in hospital both may not taking the responsibility. Ultimately you may be responsible for something happen. So this, we need to develop this insurance also, right? Dedicated transfer teams. Transport of critical illness is increasingly and is likely to continue doing so. Several reasons for, you know, this in you I think this ECMO team in Karapitiya was everybody knew during the COVID time, because this ultimate, that is the maximum care patient can get for COVID lung. So this, so I was able to work with them that time, and then their main next step is to improve the transfer of critically ill for COVID, the ECMO patients. So this is very good. So they also recognize transport of critically ill patients, because they are very ill patients. So they are sending for ECMO, and then expensive to introduce. So dedicated transfer teams are expensive, but anyway, can't help in our setup. We will slowly start these things. So in the future, we can build up nice transfer teams. The private ambulance service is also another group. They have dedicated teams, and dedicated transfer teams may reduce the complications during transfer and lessen the staff pressure at referring hospitals, right? If you know this, accept, because in earlier transfer guidelines, they accept mnemonic also considered. So assess the patient, control the situation, and communicate with the referring and send and the receiving end, and evaluate the patient and prepare and package and transport. So so if you know this, accept this, you can have all the things within that, right? Okay, thank you very much for listening, and then I invite you all to join the increase the awareness, and then the skills for transfer of critical ill, and then join us.
Thank you very much, sir. Our sincere thanks goes to Dr. Anthony Mendis, consultant intensivist in National Hospital of Sri Lanka, for his excellent and very comprehensive lecture today. And he showed us, as the recently appointed chairperson of the subcommittee for the hospital care retrieval and the transport, that there is no one better than him in the island to give us the knowledge and give us his wisdom. So once again, thank you very much. We have this slide for the health research and the innovation to Dr. Anthony Mendis for enlightening us today about this very important topic. So moving on to the question sections, there are few questions that we received today. So if there are any more questions that you have to send, you need answers from sir, you can use our email address and send it to them. Just before going into the question section, I would like to remind all of you about the method of receiving the e-certificate. You can find the link in the chat box, and you can give us your feedback, and you can receive the e-certificate for the participation also. So let's move on to the questions. Today we have a lot of questions came in. We will not be able to answer all, but in the order of that we received them. The first question, sir, can we start a method of updating ICU availability for the critically ill patients?
That is, the ministry is doing all these things. Problem is, there are, you know this, if ICU beds are available, divulge all the ICU beds. Sometimes unnecessary half-dead patients, no good prognosis, can come to the ICU. So usually most of the places, they don't divulge the ICU availability to the this check-in teams. So this so that is also very difficult, because earlier I can remember about 10 years ago, the ministry tried. So when I was acting consultant anesthetist in Mana at that time. So at least for every 6 hours, we have to update the number of ICU beds. But it is not happening in Sri Lanka because because of this problem. Because the you can't if you have enough ICU beds, so you can't refuse any bad patient. Right? Bad means bad patient should come to the ICU. That's no problem. But this very poor prognosis patient and coming and blocking the ICU beds, and then the those who really need the ICU bed may not get at that time. So because of this problem, this system has gone down, because the ministry has started this this thing about 10 years, not 10, more than that, but 12, 14 years ago. So this is very unfortunate because no proper bed allocating system in Sri Lanka. We should start that in a methodical way for this thing. All ICU consultants should get together and make a system, because if you can't do this thing by only one consultant.
Okay, thank you, sir.
Yeah.
The another question, it asks that what are the precautions in head injury patients? Probably that he's asking, the fellow doctor is asking, what are the precautions that you should take when you are transferring a head injury patient? So
that is a very good question. I have seen a lot of gaps in these head injury patients transferring from most of the patients transferring without GCS. They say they write in the transfer from GCS 14, because you know this less than if it is less than 12, so you have to intubate and send. And then some people don't know even that thing. They think usually GCS 8, usually more than GCS 8. You should not, you don't need intubation, but it is in the ICU setup or proper care setup, ICU or HDO. But if you are transferring, it will go up to 12, right? And then I say better if GCS not 15 or little confused, or this not opening his eyes spontaneously, so you should intubate and send these patients, especially head injury patients, because this on the way the hypoventilation and accumulation carbon dioxide, cerebral edema and cone. So you can save a lot of patients by. So if it is not required, after coming to the receiving end, you can remove the tube and keep, no problem. That is the problem, yes, because sometimes even in struggling patients, sometimes we sedate the patient and take the patient to CT or MRI. But ideally, you should intubate and intubate the patient and take the patient there. And once this objective is completed, so you can extubate. But they say once intubated, very difficult to extubate. So that is not a proper way. In the same way, head injury patients, you should intubate and send if there is no GCS 15. Conscious rational, without conscious rational state, you must send intubated and ventilated. Other thing is, you can do all the things that reduce the ICP. So and then there should not be tight dressings in the neck and tube ties, and then keep, if possible, keep in little head high position, and then you can give either mannitol or 3% saline during the transfer. these are the basic things you can do, and then better you can discuss with the consultant anesthetist in the neurotrauma setup at a national hospital. If you are transferring to national hospital with the neurosurgeon, not only neurosurgeon, most of the time these transfers are happening along with neurosurgeons, but this receiving and consultant is not informed. That is the other very wrong thing happening in Sri Lanka. So they don't inform the appropriate consultant in the receiving end, especially neuro head injury, because not like others, patient might die because without brain. So you can, if you preserve the brain, others you can do anything, but that without brain, no point doing anything. Therefore, we have to protect the brain first. Yeah.
Okay, thank you, sir. Adding up to the same question, there are a few questions asking about the hard cervical collar. One doctor asked, is it necessary to put a hard cervical collar in each and every patient transferred?
That is important, because trauma patients, unless proven otherwise, they have a cervical spine fracture. So therefore, this trauma patient, all trauma patients should have a cervical collar. That actually I forgot at that time. So the precautions, the cervical collar is the another very important thing, because because until you get a CT or X-ray or exclude cervical spine injury, you should have a cervical collar.
Okay, sir. Another question leading up, the same question that we've been asking. What about the pelvic fractures, sir? If there's anything else or addition to do other than the head injury for the pelvic fracture?
Yeah, main problem in the pelvic fracture is bleeding. So this, therefore, you have to check the HB level, blood transfusion, and check all these things, and then quickly transfer to the receiving end, and then stabilize the pelvic fractures, and then you should contact the trauma surgeon or this the general surgeon in the referring hospital, and stabilize the patient, because this patient might die on the way. Therefore, please stabilize the patient before sending the pelvic fractures, because a huge amount of blood loss can be there.
Okay, so another question that which is related to the slides that you have shown. Is it possible to make a common to-do list before transferring of a critical ill patient and distribute it island-wide? Is that procedure?
Yeah, that's what we are going to do, because it, along with the transfer of the critical ill audit, because you know, this when making forms are not some say it's not legalized to fill in these forms. Therefore, we are going to get the consent for the audit, and then even with that, the approval from the ministry and then the hospitals, then it will become a legalized form, because this you know, this some people don't like to fill those unnecessary forms. So we need the legal authority to use those things. That's why, because so we wait for another couple of months. It will be prepared along with the trans audit.
Okay, so with the limited time that we have, we will go for another one question. This is this doctor is asking, if a patient gets bad during transport, for how long can we stop the ambulance at a nearest hospital to stabilize? Or do we require to go to the oriented or the previously intended hospital?
That depends, because we don't know the level of deterioration, and then there is no proper time limit for that. So you have to use your brain, and then that's why you must contact your referring and consultant. So it is not purely your decision. you must contact with the receiving end, because this ultimate responsibility with the receiving end, not receiving, referring end consultant. So, so you need to discuss with the, always discuss with the referring end consultant, maybe hours, or maybe sometimes keeping that patient for few minutes for the sucking out secretions, that type of thing. So you can't exactly say the time. So better to contact with the referring consultant.
Yes, because it was a short question, sir. We can go for one more question. If a patient underwent a needle thoracosynthesis at our local hospital, how can we transfer the patient to the tertiary care center, and is it necessary?
So this, so that's why, so we have to check the ABC of the patient. Once stabilized, so I don't recommend destabilized patient transferring. So discuss with the primary this referring consultant, and then the check the anyway. This is primary consultant's duty to stabilize and send. So this if this patient need lines, and then there may be hemothorax, pneumothorax, so you need to put IC tubes, and then checking all these things before anyway. We are not expecting a deterioration during the transfer, so we have to stabilize and send. Can't hear.
Yeah, thank you, sir. Thank you very much once again, Dr. Anthony Mendis, consultant intensivist, for joining hand with us today. So sincere thank goes behalf of the Society for the Health Research and Innovation to sir for joining today and giving a very comprehensive and a very detailed lecture. So I hope all of you will join in next Sunday also for a similar session of CPD. Until that, thank you very much for joining today, and hope to see you next week. Thank you.
Thank you.